Do you know anyone suffering from shortness of breath while at rest or tiring easily from daily activities? Your grandmother, grandfather, or an older loved one may be suffering from chronic obstructive pulmonary disease, also known as COPD, which we will be presenting on today. We will begin with a general overview of COPD and lung functioning, moving into the specific condition emphysema and how it affects the lungs. We will then go more into depth with who is at risk, prevalence data, treatment methods, and ending with public health prevention strategies. The Center for Disease Control defines COPD as a group of diseases that cause airflow blockage and breathing-related problems. It includes emphysema, chronic bronchitis, and asthma. How do our lungs function? Elastin, a fibrous connective tissue that acts like rubber, is found all throughout our body. Elastin can be stretched to several times its length but will recoil to its original shape when relaxed. This is what allows our lungs to expand when we inhale, then return to their resting position when we exhale. Alveoli are small air sacs located at the end of bronchioles. They are the primary site of gas exchange. With lost elasticity, alveoli will harden and make it difficult to expel air. Why does COPD make it hard to breathe? Well, in the case of emphysema, a person's alveoli become damaged and lose their elasticity, as well as their shape. As air spaces get larger, air gets trapped in the alveoli, and there are fewer air sacs to provide oxygen to the blood. This trapped air makes it harder to get air into and out of the lungs, making it harder to breathe. Here's a short video to further demonstrate lung function and COPD.
In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes, of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult.
Smoking causes inflammation in the airways. Immune cells like neutrophils are recruited to the small airways where they release proteases and oxidative species. Proteases released by these inflammatory cells break down the connective tissue of the alveolar wall and septae. Neutrophil elastase breaks down elastin fibers responsible for elastic recoil during expiration. A loss of elastic recoil leads to diminished expiratory flow rates, air trapping, and airway collapse.
Emphysema is a progressive condition that in many people begins asymptomatically and gradually develops symptoms over the years. Some of the most common symptoms include shortness of breath even when at rest, constant coughing, increased mucus production, and wheezing. Many emphysema cases go undiagnosed since its symptoms are so similar to other non-threatening conditions. COPD is one of the 10 leading causes of disability in the United States and is among the 4th leading cause of death in the U.S. As of 2017, over 16 million U.S. adults were diagnosed with COPD, and of those people, about 3.5 million U.S. adults were diagnosed with emphysema. The national economic burden for COPD in the U.S. is almost $50 million annually, including healthcare costs and both indirect morbidity and mortality costs. Some social and behavioral risk factors include smoking, secondhand smoke, a history of respiratory infections, and occupational exposure. Smoking is the number one risk factor. with 85 to 90% of chronic obstructive pulmonary disease cases caused by smoking. Exposures to air pollutants at home, like secondhand smoke, heating gas, as well as work exposures to dust, gas, and fumes all contribute to the development of chronic obstructive pulmonary diseases. There are many demographic factors that can affect the development of COPD, including age, sex, ethnicity, and income level. When looking at age, people who are 65 years or older are more likely to develop COPD than those younger than them. This could be because as we age, our normal lung function begins to decrease and fatigue on its own. COPD had previously been considered a man's disease, but with the increase in smoking amongst women over the past 30 years, the sex difference has declined. We are now seeing that fewer men are dying from COPD than in the past, whereas women's death rates have actually been steadily increasing throughout the years. Today, there are more women than men living with COPD and more women dying from it as well. In terms of ethnicities, non-Hispanic white women are most likely to develop a COPD, followed by non-Hispanic black women. Income level, like in many other health conditions, also plays a role in the distribution of COPD cases. People who are considered low income were at the highest risk when compared to other socioeconomic groups for developing COPD. In fact, more than 90% of COPD deaths occur in low and middle income countries. There are also genetic predispositions like history of asthma or alpha 1 deficiency that can potentially cause COPD, especially if they are already a smoker.
As you can see on this graph, the distribution for COPD isn't evenly spread throughout the country. In fact, the highest prevalence for COPD is found in the southeast region of the country, which includes states like Alabama and Tennessee, with prevalence rates ranging from 7.6 to 12.3%. On the other hand, states with the lowest prevalence rates include California and Utah, ranging from 3.5 to 4.7%. Globally, an estimated 328 million people have COPD worldwide, and in 15 years, COPD is expected to become the leading cause of death. The prevalence of tobacco smoking appears to be increasing in the eastern Mediterranean and Africa, which could explain the increased prevalence of COPD. Historically, women have had lower prevalence rates of emphysema than men. However, this trend may be changing. Over the past 5 years in the U.S., the prevalence rate among women has increased by more than 63% compared to a decrease of 6% in men. In fact, women actually surpassed men in 2011. 21.4 per 1,000 women had emphysema, which is about 2.5 million, compared to 19 per 1,000 men. In 2011, 4.7 million Americans reported being diagnosed with emphysema, a lifetime prevalence rate of 20.2 per 1,000 persons, and over 90% of emphysema cases were in individuals over the age of 45 years. Historically, emphysema has been about twice as common among non-Hispanic whites as non-Hispanic blacks. However, 2011 saw a significant increase in emphysema prevalence for the latter that closed the racial gap. In 2011, an estimated 3.8 million non-Hispanic whites had ever been diagnosed with emphysema, compared to an estimated 489,000 non-Hispanic blacks. Going forward, the following general COPD data does not include the condition asthma. So as seen in Figure 4, the age-adjusted death rate in non-Hispanic whites, 46 per 100,000 people, was 1.7, 2.6, and 3.1 times greater than the rate in non-Hispanic blacks, Hispanics, and non-Hispanic others, respectively. Overall, non-Hispanic white males had the highest age-adjusted death rate, 53 per 100,000 people, while non-Hispanic other women had the lowest age-adjusted death rate, 11 per 100,000 people. In 2009, the age-adjusted death rate in San Diego County are similar to the ones we saw nationally in the last graph, with whites still being amongst the highest with 34.5 deaths per 100,000 people. Screening methods for emphysema include chest x-rays, pulmonary function tests, and CT scans, which help determine if surgery is needed. Arterial blood gas analysis can also be used to test how well your lungs are bringing oxygen into the blood and removing carbon dioxide. According to the Health and Human Services Department, COPD cannot be cured, but there are treatments and lifestyle changes that can slow the progression of the disease. For example, vaccines, pulmonary rehabilitation, oxygen therapy, and surgery can help.
According to the Health and Human Services Agency of San Diego, the number one factor for COPD is smoking. Thus, the number one prevention is to avoid smoking, which includes avoiding secondhand smoke. Making your home smoke-free is the first step to preventing the onset of COPD for yourself and your family. It's also important to remember that pollutants also contribute to COPD development and therefore also need to be targeted as preventative strategies. Some of these include making sure your home and work is free of any harmful chemicals, dust, or fumes, and fighting to improve the air quality in your community. The Truth Campaign focuses on spreading awareness and inspiring action to fight the end of smoking and vaping. They make creative videos that target young viewers with facts about tobacco, opioids, and vaping. They also provide other resources to help quit smoking and vaping. There are 3 programs that help people to quit smoking: the American Lung Association Freedom from Smoking Program, the California Smokers Helpline, and locally the Smoke Free San Diego website. The American Lung Association Freedom from Smoking Program was ranked the most effective smoking cessation program. It provides a personalized plan to quit, strategies for managing stress, weight, and exercise management. They educate people on methods to quit smoking, different medications, and life support from smoking specialists. The Department of Health and Human Services funds both the California Smokers Helpline and Smoke Free San Diego. The California Smokers Helpline provides the 1-800-NO-BUTS telephone line, which supplies free counseling. The program is offered in several languages, ranging from Spanish to Mandarin to Korean. SmokeFreeSanDiego.org can help you or your loved ones quit smoking. If you are in Medi-Cal, smoking cessation classes are also offered, and nicotine replacement therapy may be covered.
Some nonprofit organizations include the American Lung Association that provides lung health education, lung disease research, support services, programs, as well as advocacy. And the American Association for Respiratory Care promotes advances in the science and practice of respiratory care and serves as an advocate for patients, families, and respiratory therapists.
The Healthy People 2020 goal is to promote respiratory health through better prevention, detection, treatment, and education efforts. Healthy People 2020 have 4 general objectives targeted towards COPD. The first is to reduce activity limitations amongst those with COPD, considering that 23.2% of adults living with this condition expressed having difficulty with certain movements or activities. The second is to reduce the number of deaths due to COPD from about 114 per 100,000 adults to about 103 per 100,000 adults. The third and fourth objective are to lower the number of hospitalizations and lower the number of emergency department visits accounting for COPD. The fifth objective, to increase the proportion of adults with diagnosed COPD, was archived in 2015 because of insufficient viable data and concerns for biases in the data collected. Their plan of action to reach these objectives includes executing strategies like increasing the price of tobacco products, enacting comprehensive smoke-free policies, and implementing hard-hitting anti-tobacco media campaigns. Healthy People 2020 also works to expand access to proven treatment methods in clinical care settings to all smokers and reduce tobacco advertisement, including e-cigarettes, combustibles, and non-combustible products directed at children.
High taxes on tobacco products have been proven to reduce tobacco use, especially among youth, thus being an effective preventative measure for COPD. There is currently a federal tobacco tax on cigarettes, which is $1.01 per pack, since the last time it was increased in 2009. The funds go towards funding programs that support children and adults across the country, including the Children's Health Insurance Program, also known as CHIP. CHIP provides health insurance to children who would otherwise be uninsured. There is also a state tobacco tax that varies between states, but the average state cigarette tax is $1.78 per pack as of October 2018. According to the American Lung Association, the highest state tobacco tax is in Connecticut with a tax of $4.35, and the lowest state cigarette tax is in Missouri with a tax of 17 cents. When we compare it to the CDC graph for prevalence of COPD among adults in the U.S. by state, the prevalence of COPD in Missouri is 6.5 to 7.5%, while the prevalence of COPD in Connecticut is 3.5 to 4.7%, further demonstrating that taxation is effective. Knowing how effective taxation has been in several states by reducing the prevalence of COPD, we know there are steps we can take to decrease our risk for developing such disease. Some of these include getting involved with the virtual lobby campaign social media toolkit to spread educational information and lobby for COPD interventions. You can also utilize the Truth Campaign's platform and resources to promote the cessation of smoking on social media through the use of hashtags like #finishit and #I'dRatherBuy. Lastly, public health students can call their representatives to encourage them to increase taxation on tobacco products and to enforce other smoking regulations.
You can take action by following us on Twitter at Say No to COPD. Thank you for listening.